Hello everyone, I'm Dr. Tushar Mehta. I'm an orthopedic surgeon and a national level faculty of orthopedics for undergraduates as well as postgraduates. So let's talk about the topic for the day. We will not be actually talking about the topic first. We'll be looking at this X-ray. We'll be looking at this image first. What do you see in this image? When this image floats on any of the social media groups, the first thing that I see often, which is said by the PG aspirants, is that it's a fracture of the patella. Well, okay, but it is not. It is not fracture of the patella. It is a condition that is what is called as bipartite patella. Now we'll talk about this bipartite patella. What is this condition? It's a congenital condition which is caused by failure of the ossification centers of the patella. I'll tell you. Every bone has got ossification centers. Yes, so does patella. Now, ideally, the ossification centers of the patella should fuse with each other. When they don't do that, you get something as a congenital condition that is what is called as bipartite patella. Always asymptomatic, just an incidental diagnosis, and honestly does not require any treatment. Now, you might be wondering that if it is asymptomatic, if it is diagnosed incidentally, which usually does not require any treatment, then why are we even talking about it? It's a very important and famous radiology spotter. It is actually nothing but a variant of the normal patella, which just shows that yes, there is no fusion of the ossification centers that has happened. But now I'm going to tell you the importance. The importance is something that you all said that it looks like to be a fracture of the patella. So it's a developmental variant where ossification centers have not fused. But the problem is there are two problems. One, as a student, it's an important radiology spotter. The second important problem is that it is often confused with patella fractures. Don't worry, we will talk about that. First, let's talk about the epidemiology. First, let's talk about the epidemiology. Now, when we talk about the epidemiology, usually 2 to 3% of the total population is affected. I mean, incidence is not that much. There is no sex predilection. There is no male female thing that is in this. But yes, there is one thing that I would certainly want all of you to remember to notice this, that it is usually bilateral in 50% of the people. And I'm sure in this image, you all can very well see that in this X-ray, it is bilateral. So I want you to know that it is usually bilateral in 50% of the population. And there's one more important point in epidemiology, that it is usually seen in the supralateral region, that is called the type 3. Don't worry, we'll talk about that. That is something which is called as the SOP classification. So we'll talk about that. But yes, as you can see in this image also, that it is usually seen in the supralateral position. Let's talk about the pathophysiology. So I have already told you that bipartite patella is technically just a developmental variant where ossification centers of the patella, they fail to fuse. Okay. Now, I told you that the problem is there were two issues that I told you. One, as a student, it's a radiology spotter, so you are supposed to know about it. Two, you get confused on an X-ray that whether it is a patella fracture or not. Okay. Now I'll tell you something more important about it. Now the problem is, let's say an asymptomatic person who has got a bipartite patella sustains an injury during sports or during some household domestic chores or whatever. Now he gets injured at that area. Now the biggest problem is that this fragment of the patella which has not fused, while this is the remaining patella, they have a fibrocartilaginous bar in between them. मेरी बात समझ रहे हैं आप? So the failure of the ossification has happened, but that area where it was supposed to be ossified, now that has been replaced by some fibrocartilaginous tissue. Now the problem is during that injury, that fibrocartilaginous area that gets injured, that gets disrupted because of that injury. So the main patella and this accessory fragment, there's a fibrocartilaginous tissue, and that fibrocartilaginous tissue, because of the injury, gets injured. Now it's a fibrocartilage. It is not a bone which has been fractured and it will take its own due course of time and it will unite. No, it's a fibrocartilaginous part. It has been disrupted. Now that is the cause of a persistent knee pain. That is a cause of persistent knee pain. There might be many reasons for it. First, because of the injury, the arterial supply, the arterial penetration from the main fragment to the accessory fragment was through the fibrocartilaginous bar, and because of the injury, the arterial supply has been disrupted. So there's quite a possibility that this accessory fragment might go into infarction. Another problem is, I'll tell you, that in usually majority are in the supralateral part. So there is a vastus lateralis muscle which usually gets connected to that part. So that constantly pulls that fragment towards itself, and that also leads to a persistent traction kind of a injury. Are you able to understand my point? So again, I'm repeating this for you because in this topic there is hardly anything. In this topic, there are only three major things. Number one, it's a good radiology spotter. Number two, it can be confused with patella fractures. Don't worry, we are going to discuss that as well in due course of time. Number three, the problem is that when you have an injury, a knee can get injury because of anything. You're walking in your home and suddenly, there's a table, there's a chair, there's a bed, and one corner of that bed, you get hit from that. So when that happens, then this fibrocartilaginous bar between the main fragment and the accessory fragment gets injured. And since it is just a cartilage, it is not a bone, it is not going to unite on its own, and therefore cartilage has got a poor healing, and therefore it is the reason for the persistent knee pain. I told you the hypothesis. I told you there will be disruption of the arterial channels. I told you there will be disruption of the arterial channels, even the accessory fragment might go into infarction. The second reason that I told you was that vastus lateralis will keep on pulling that accessory fragment. Are we able to connect these points now? I have told you almost 5 times till now that the major issue is that when you see this on an X-ray, why it is an important spotter, because students have a tendency to call it a patella fracture. Now let's differentiate it with patella fracture. Number one, they are usually located supralaterally. First thing. Second thing, these X-rays of bipartite patella, where you have the accessory fragment, they usually have smooth rounded borders. Do you expect a fracture to have a border like this? Do you expect a fracture to have a border like this? No, you don't expect. A fracture will have a rugged surface, a raw surface with sharp surfaces. With when a fracture happens, you see serrations in the fracture fragment. So here you have a smooth rounded border. Number one. Number two, they are supralateral. Number three, how can just look at this X-ray? How can you assume someone to have a bilateral patella fracture? आदमी ऐसे कैसे, it is not possible, na? So the difference is, number one is usually in their bipartite patella is usually seen in the supralateral part, 75% cases. Number two, there are smooth rounded borders. Number three, bipartite patella will be usually bilateral. So anytime if you're confused with a bipartite patella with a patella fracture, you always ask for an X-ray of the contralateral of the opposite side also. So if something is there which looks like to be a patella fracture, but if the borders are smooth and rounded, the location is supralateral and it is present bilaterally, the first diagnosis is not patella fracture, it is bipartite patella. Now we'll talk about the classification that I mentioned, sub-classification. So in sub-classification, there are three types of bipartite patella: type 1, type 2, type 3. Type 1 is the least common, hardly 5%, inferior pole. I don't know whether you are able to see this or not, but yes, this is type 1. If you can see, this is type 1. This is inferior pole. Just 5%. Just 5%, nothing much. Type 2 is the lateral margin. I hope that you appreciate this as well. Lateral margin. Some people have messaged me, asked me, when I take live lectures also for PG residents, sir, this is the supralateral thing. No. Type 1 was inferior pole, type 2 is lateral margin. This is lateral margin. This is around 20%. You can see the classical round convex borders. And now I'll show you the type 3, which is the most common type, which is seen in 75% of the cases, Now, lateral is different. Supralateral, if you see, this is, just hold on, this is supralateral. This is supralateral. This is supralateral. So this is basically type 3. You understand my point? This is the most common. This is supralateral. The best way to identify is always in X-ray. There is no confusion at all. In X-ray, I always advise the perfect view, the best view is always the AP view. So you get an AP view, you look for convex rounded smooth borders, You look for supralateral location, you look for the presence of the bilaterality. Then there is a skyline view. I'll show you one example of the skyline view also. Skyline view, they say that it should be getting two views, like in two positions. One is the prone position, which is a non-weight bearing position. Another one is the squatting position, which is the weight bearing position. Now, always consider an X-ray of the opposite need to look for bilaterality, because if there is a bilaterality, then always it goes towards the presence of the bipartite patella. So now you can take a look on the left-hand side. You have a classical AP view. So this is a classical supralateral bipartite bilateral patella. आप समझ रहे हैं? So this is the classical supralateral. It is not lateral. It is supralateral. This is, so if I have to read this X-ray, I will say, okay, fine. This is an X-ray of both the knees, including the distal half of the femur and the proximal half of the proximal part of the tibia and the fibula. Okay, in the anteroposterior view, most likely in the standing position, with bilateral bipartite patella located in the supralateral quadrants, most likely SOP type 3, which is the most common type. Okay, now this is what you see is this is the skyline view, and I'm sure you can appreciate in the skyline view, you can appreciate it like that. So this is a classical X-ray of the bipartite patella, which is usually asked. Now the bilaterality which is shown here should immediately take you towards a diagnosis of bipartite patella rather than any patella fracture. Now MRI, I have personally used an MRI in one of the cases. So there was a case which I saw, there was a persistent anterior knee pain. I got an X-ray done, there was nothing. I asked for an MRI, somehow the family was delaying and certain things happened. And then there was a persistent knee pain which was there. Now listen to me carefully. They got an MRI. They did not come to me and some very known to my family. So they sent me the printed report of the MRI. No meniscal injury, no cruciate injury, no blah, 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 nothing. Just mild sprain and one of the menisci, stuff like that. Now I said, the MRI is not explaining the pain that you have. You are clinically symptomatic, but MRI is probably not showing me anything. So I think we should meet and you should come. I mean, this telephonic thing is not going to work. So when they came to me, I looked at the MRI films. I had a doubt. I asked for a second review from a radiologist, and the radiologist clearly told me that it's a bipartite patella. Guys, believe me, if there is a bipartite patella, ideally we see on an X-ray, yes or no? Yes. Yes, but it was a bipartite patella, which was unilateral, which was hardly visualized on an X-ray. Actually, what happened, I'll tell you, there was a fibrocartilaginous bar, as I told you, because of that injury that got disrupted, as I told you. Now, that was the reason for the persistent knee pain. So I could see the edema, and the radiologist could confirm the edema around the accessory fragment and the main patella fragment. So he said that there is not edema around the patella, there is edema within the patella. I said, why? What are you saying? He said there is edema within the two fragments of the patella, the main and the accessory fragment. So this is something from that day till today. I mean, you are a man of your, I mean, you are the end product of your own mistakes and miseries. So from that day till today, whenever I'm dealing with a simple knee injury, I'm dealing with a meniscal or a cruciate or a collateral or a capsular or any ligament injury, I always ensure that, I look at the patella and I look for edema around the patella and within the patella. So that's probably a learning treatment. I told you initially in the first couple of slides that majority of the cases are asymptomatic, they're instantly diagnosed, they have hardly anything to do. So I think rest is best. If there is a acute injury that happens, then non-steroidal anti-inflammatory drugs are good. Quadriceps exercises are important. Minimum duration for this should be 6 to 8 months, and strengthening your quadriceps, I think, is the best thing. So if I see an asymptomatic bipartite patella, I'm not going to prescribe him rest. I'm not going to prescribe him some sort of painkillers. Are you able to understand? I'm going to prescribe him just quadriceps strengthening exercises, because that is the only thing which is going to protect him from any further injury, or even if injury happens, a strong muscle will compensate for that injury. But yes, if injury happens or if anything happens, the first attempt is always for conservative treatment for 6 to 8 months. But yes, if there are certain cases who develop a persistent knee pain or who develop a certain kind of attraction because of the vastus lateralis, then we will have to, call them as a symptomatic painful bipartite patella, and then we plan the surgery. Guys, I'll be very honest. The first surgery is always open excision. So just like a typical patella fracture, you have to open that area, you have to excise that accessory fragment. I've seen people doing arthroscopic excision. I have tried in a couple of cases. I'll be very honest. I'm not very happy. I'm more comfortable with open. I mean, this is just a personal opinion. But yes, textbook teaching says that open excision is one treatment modality, then arthroscopic excision is one modality. In fact, during when you do that, whether you do it arthroscopically or whether you do it with open excision, the thing is that the lateral retinacular release has to be done, or probably one should see for the lateral retinaculum, probably one should see for the vastus lateralis. And if you think that that is the reason for, persistent traction, then you have to tackle that as well. You have to release that as well. Well, textbook also says that open reduction internal fixation has been attempted, and people, they've put two screws between the accessory fragment and the main fragment. So this is also one of the textbook treatments. If there is a significant, I'll tell you the reason. If there is a significant size of the accessory fragment, you might be wondering why. So if there is a significant size of the accessory fragment, then you're supposed to fix it. You cannot remove such an accessory fragment. By the way, why you can't remove if the accessory fragment is big, why can't you remove it? You're going to land up into patellofemoral incongruity. आप समझ रहे हो? You're going to land up into the quadriceps weakness. So that is why even that is postulated as one of the treatments. Complication, as I told you, the biggest complication is patellofemoral maltracking. That patellofemoral maltracking will lead to early patellofemoral degenerative changes. So that is why in young people, when we see bipartite patella, we weigh the two things, that if the patient is not having any classical symptoms or persistent symptoms, then we try to avoid surgery, because in surgery there is quite a possibility that how much careful you are, but still there is some maltracking can happen. There's possibility of some early degenerative changes can happen. After excision, guys, let me tell you, effusion is a very common complication, because you're removing a kind of a chunk from there. So that can be the reason for effusion. Persistent pain can happen. Weakness of quadriceps, as I told you, that is certainly one complication. So these are the potential complications that I think that you guys should be aware of. And so with this, we come towards the end of the topic. And again, I would like to show you the classical bipartite patella. The bilateral bipartite patella, normally seen in 50% of the population. Bilaterality, usually seen in the supralateral corner. So I hope you benefit from this video. We spoke about a normal developmental variant where ossification centers fail to fuse, particularly in patella. Again, three important reasons. Radiology spotter. B, it is often confused with patella fractures. C, if it leads to the injury of the fibrocartilage between the accessory and the main fragment, that is reason for the persistent knee pain, which can be problematic for your patients and for you as a clinician. So if you have any questions and if you have any suggestions about this topic, you feel free to post as a comment below the video. And thank you so much. The coming videos are usually, I'm posting the next video again on a congenital anomaly that will be the congenital radio-ulnar synostosis, and along with that we will be talking about mid-lungs deformity as well, and the congenital muscular torticollis. So next three videos, I've already given you the schedule for that. So that will be congenital radio-ulnar synostosis, mid-lungs deformity, and the third one will be congenital muscular torticollis. So just go through this, let me know any reviews, any comments or compliments. So thank you so much. Have a great day. Bye bye.